Thank you, Bob. Just have a couple of slides to just kind of paint an overview for you folks as to what you're going to see next. Robin Shermis is from ProMedica in Toledo. We have installed what's called Volpara Analytics at his site. So we're able to calculate density, we're able to calculate dose. What the analytics product is that it is a way to tie the two together. Think of this as we are going through your DICOM header. We know all of your procedure information. For those of you who aren't aware, that comes out with each mammo image is taken, excuse me. We then take that information and we analyze it. And what we do is we present that information to the customer in a fashion that enables you to look at your density, understand your population of your patients, understand your population of your technologists, as well as your individual facilities. So combining the DICOM header, calculating density, calculating dose, is Volpara Analytics. That's kind of the background behind it. Now I'll turn it over to Dr. Shermis. He can share some information for you.
Okay, thank you. I have a couple of disclosures I need to make. Number one, I'm not being paid by Volpara to be here today. I'm doing this on my own. Number two, I almost failed the physics part of the radiology boards. I'm not a big physics kind of guy, but I understand the importance of it clinically, because we are talking about something that is coming up a lot, and that's density and dose. And if your practice is like mine, I mean, it's sort of accelerating. I work at a large tertiary facility in Toledo, Ohio, which is the center of the universe. And we have a very busy practice. We do about 50,000 examinations a year, and we try to feel like we're doing a pretty good job. But this is our workflow. And, oops. I'm showing this, I don't want you to freak out by looking at this, but I'm showing this to tell you that in any large breast care center, there's a lot of moving parts. And Volpara has made my life a lot easier, because in order to get down some of these pathways takes input of a lot of information. Specifically, we do a lot of screening breast MRI for high-risk women, and we actually do a lot of screening MBI for non-high-risk women. And we have to assess their breast tissue density to justify exactly why we're doing those studies, to present to the insurance companies and our referring physicians. The way we do this is subjectively, which is okay, but there's a lot, in our group, there's a lot of interdepartmental variability in what someone thinks is dense. Even through a classic spectrum like this, a fatty, a scattered, heterogeneously dense, and very dense. So subjective is a helpful thing, and in experienced breast imagers, you can make generally a good guess, but I think we need to have more information, and that's where the objective information comes from Volpara. Volpara actually will give us the BIRADS density, and as part of your examination, when you're reading this, this will come up on your monitor. It will assess the volumetric density and then give you a scale where that density falls in the range of our 4 categories. Now A, B, C, and D, and this is the older lexicon. The new BIRADS talks about how hard it is to estimate volumetric density, and it's impossible to do realistically as an observer reading the mammogram. You need a lot more information to do that. So we actually, on our mammogram, we assess it. Volpara will assess it. And then actually, Volpara will automatically populate our PenRad information system. We could overrule that, but the automatic population is a great thing. Most of the time, I don't disagree with Volpara. And it's an awesome system. We also can use that information to directly send letters to the patient and reports to the referring physicians if we're going to make additional recommendations in screening. This is an interesting thing. It's fairly interesting. If women have a kind of a misunderstanding of what dose is. A lot of women will overestimate the dose risk they get. And that's partly due to the culture, a lot of pop literature that's out there, but it's a scary thing for women. And I believe a lot of women, their level of compliance is based on getting their mammogram. They think, I'm getting this whopping amount of dose, and maybe I won't get my mammogram every year, maybe I'll get it every other year or every 3 years. And that's a big deal. Compliance is good for a good thing if we're going to catch cancer at an earlier stage. So there is a definite idea that women have an overestimation of how much radiation they're getting for an examination in mammography. But if you do talk to women, they actually are willing to, there's a risk benefit in getting that examination, and they're willing to tolerate levels of radiation if they understand that, if the benefit's going to be good, like a mammogram. This is some of the analytical information you get from Volpara. It basically comes in a dashboard, and you can access it through the web, or you can have reports sent to you by Volpara. But it gives you some really cool information. It could tell you a lot about your patient population. This is not our entire population, but selected machines. What is crucial here for us in terms of resource allocation is how many patients do we have that are dense? And it's about 40%. Knowing that then, and knowing our high-risk population levels, and how many women we're going to have to additionally screen who aren't high risk with MBI, we have a good feel for the resources needed to do that. And it will tell us pretty explicitly that monitoring your patient population over the entire facilities, what percentage fall into each category. And it's nice to have that snapshot. And in addition, you can get ideas about your patient population and their density as they age. And also the information here with dense versus fatty breast tissue with age. And these are just kind of nice snapshots to get an understanding, a feel for your population as you're evaluating resource allocation. This is pretty interesting aspect of one of the dashboards you can get, is that you can look through here at the different levels of density, and you can see that at all our different mammographic facilities, we're getting an even spread percentage-wise of which patients fall into each category. 1, 2, 3, and 4 are now A, B, C, and D. And you can see at all these facilities that it falls into pretty regular, consistent patterns. Some rather useful information we get also from this is that we can look at our technologists, and we can actually assess how well they're doing. One thing we can do here is we can look at their medium pressure applied throughout the spectrum of our technologists, and we could look for variances. And we can see here there are 4, usually you want a compression applied somewhere around 9 or 10. We have 4 operators, technologists, who are significantly departed from those ranges. What does that mean? Well, it can mean one of 2 things. It can mean that potentially there's something wrong with the machine they're using, or if that's not the case, that these women are out of whack with the pressure they should be applying. And in our facility, there's one of our hospitals, they have 4 women there. They're sort of only a screening facility. And these 4 women are all attached to that one facility. And it wasn't the machine. These are women who all were applying consistently lower pressure. We identified that. We kind of subjectively knew that as well because their images often were unsharp. These are women also that with lower compression are getting a higher radiation dose, and that's a bad thing. So we're able to isolate potential patterns within technologists where we can intervene and say, you have to increase your pressure application. We also can, this is a complicated chart, but just look at the circles there. We also can look at mean dose that each individual techs are applying, and you can see here there are 2 that are a little away from the others. One is a low, 1.47, one is high, over 2, and these doses then can translate into something that they might be doing as well. Too much compression, too little compression, And that also, women who are applying too much compression can also translate into complaints about, I had a bad examination. So monitoring the QA is very important when you're looking at the whole spectrum of technologists and machines. You want to know exactly what's going on. This could have significant impact on workflow and quality and honestly, how well your facility is doing. That's all I had to say. Any questions? Thank you very much.